Right?
All right, I'm going to shut my window.
Yep.
Because I want to make sure that what we're actually seeing is your window. All right, now I'm going to hit. Hello, welcome to a presentation for the Open Doors Transition Specialist. Today we welcome Glenn Lieben and John Richter from MHANYS, from the Mental Health Association of New York State, who have done this presentation for all the transition specialists, and we are doing this as a webinar for any new transition specialists. So without further ado, I'm going to turn this over to Glenn Lieben.
Thank you very much, Suzanne. First of all, I really want to thank Suzanne and Lindsay and the folks from the Independent Living Center for this opportunity. John and I have now traversed the state, I believe about 10 or 11 times, including speaking at the annual ILC conference, talking about this issue specifically. And it's been an eye-opener for, I think, both of us. We've learned a lot from all of you. The discussions have been very robust about this issue, and it's really raised a lot of issues to the state. And frankly, a lot of our conversation has ended up in some state discussion around policy issues. So this is really significant, and it's been a real great opportunity to find out what you are all doing on a daily basis and how we can help hopefully provide some significant information to you. The feedback we've received has been very positive. So hopefully, you'll get some worthwhile information out of it. So the way we parse it out is John's going to speak first about transitioning nursing homes with residents with mental illness to the community, and he's going to talk about when somebody is in a nursing home and how to work with them in terms of advocacy to bring them into the community. Then I will take it from there and talk about the services that are available in the community, including some of the new services that are available around Medicaid managed care. So at this point, I'd like to introduce John Richter. John is our public policy director, and he's going to take it from there. Thank you, John.
Well, thank you, Glenn, and thank you, Suzanne, and thank you, everybody, for joining us today and spending some of your time to get better acquainted with some of the unique needs of people living in nursing homes with mental illness, and then also how to meet some of those needs when it comes to trying to transition them into community living. So, as Glenn said, we will present this in two parts, and I'll begin let's begin in the nursing home and actually talk about, who are people who are living in nursing homes with mental illnesses? Why are they there? Why are they there in such large numbers in some cases? And then how do we determine whether or not somebody has a mental illness in the first place? How does that drive decisions about the care that they need in the nursing home? And importantly for you all as transition specialists and others who are helping people in the nursing home to transition into the community, what kinds of things might we look for that would help us to plan a successful transfer into living in the community? So as you can see here, I've got an overview up on the screen here of where we're going to go today, and you'll see that it ends with a section on mental health literacy training for transition specialists. So after I get done presenting the bulk of part one, I'll end with just a recommendation for a type of training I think would be very helpful for all of you in working with the people who you work with in nursing homes who may have mental illnesses. So with that, I'll begin. And where I like to begin this presentation is with the Olmstead Decision. And I'm sure most of you are well acquainted with the Olmstead Decision. So I'm not going to talk about what it is, but what I am going to do is begin by reminding folks that what was for our discussion today, what's important about the Olmstead Decision is the original plaintiffs actually were women who were living with intellectual disabilities and with mental illnesses. Actually, not physical disabilities, but mental disabilities. And yet they remained languishing in the mental health unit of a hospital in Georgia, and became the well-known plaintiffs in this particular case. So I like to begin there again as a reminder that mental illnesses can be very disabling, and often times result in people being institutionalized unnecessarily. So let's talk about the prevalence, if we can, for a moment, about people who are living in nursing homes with mental illnesses. And the prevalence level is actually quite high. And you can see by the statistics that I've got up on the screen here right now, is that there are about 10 times as many people living in nursing homes with mental illnesses than who are living in psychiatric hospitals. So 500,000 people nationwide who are living in nursing homes with mental illnesses, and that's excluding dementia, which we'll talk about a little bit later. Dementia is not a mental illness, so I just want to make that clear from the get-go. But just understand that there are a lot of people who are living in nursing homes who probably with mental illnesses who probably could be cared for in other settings that would be more appropriate to their needs. So you also see that there's a high level of depression in nursing homes. About 49% of people living in long-term care settings have depression. And that's significantly higher than the level of depression in the general population. So, for example, about 19% of people who were admitted to nursing homes had some kind of a mental illness, such as depression. Excuse me for a moment. Did not mean to do that. But so what we have is we've got people who are admitted to the nursing home with levels of mental illness that are more or less on par with what we see in the general population, while people living in the nursing home have significantly higher rates of mental illness than people who are in the general population. So you have to wonder what's going on there. Why are levels, what would appear to be happening, why are levels going up when people are living in the nursing home as compared to when they first entered? So we'll be talking a little bit about what some of those reasons might be. But just to show you that this is true also in New York, you'll see by this slide that draw your attention to the two bolded numbers there, 2.6 and 23.6. And what you see here is New York statistics compared to the nation as a whole. That 2.6% relates to the first 1 and 2 of the mental illness diagnoses that are listed there on the lower left portion of your screen. So schizophrenia and bipolar disorder, the levels of people being admitted to nursing homes is 2.6. And that also, again, is similar to what we see in the general population. When you consider all of those diagnoses, 1 through 4, the level is 23.6% of people entering New York nursing homes have one of those or more of those disorders. And again, that's consistent with what we see in the general population. So just to show you that New York is really no different, and in some cases maybe slightly less than the nation, but certainly consistent with what we see nationwide. You know, there are a lot of people living in nursing homes with mental illness, and whatever is going on with regard to why they're admitted and why they're living in there, it's contributing to young people being younger in nursing homes to this trend. So if we look, for example, at the growth of people living in nursing homes between the years of 1999 and present, you'll see an increase in young people between the ages of 21 and 65 has increased from 11% to 15%. And that's ironic and unfortunate, considering that 1999 was the year when the Olmstead Decision came down. So things have actually been going in the opposite direction from where they should in a state that is supposed to be Olmstead compliant. And I'd like to talk a little bit about why that may be happening, why this people with mental illnesses being admitted to the nursing home, or at least becoming mentally ill while they're in the nursing home, and how that's contributing to younger people living in the nursing home. So already I've been talking a lot about mental illness, mental disorders, and mental diagnosis. So I think before I go any further, I should qualify some of my terms so that we're all on the same page. When we talk about a mental disorder, what makes somebody mentally ill? How do we know if they've got a diagnosis or if they have what we call a disorder? Mental illnesses, unlike physical illnesses, aren't as easy to determine. For example, we don't have a blood test that we can give somebody, or a brain scan, for example, to give somebody to say that they definitively do or don't have a mental illness. Instead, clinicians use a variety of criteria and symptoms to determine whether someone has a disorder or not. And in a mental disorder or an illness, it's a diagnosable illness where the symptoms affect a person's thinking, their emotional state, or their behavior. And importantly, when a person is experiencing those symptoms, it's important to establish that those symptoms are in fact disrupting a person's ability to work, to carry out daily activities, or engage in satisfying relationships. So sometimes we'll talk about a person who might be having some mental health symptoms or mental health problems or challenges. We sometimes use that to differentiate from people who have a disorder because, quite frankly, sometimes people can have some symptoms, but those symptoms don't necessarily rise to the level of an illness or a disorder because they're not impacting significantly a person's ability to work, carry out daily activities, or engage in satisfying relationships. So an example might be you might have some, a runny nose and feel a little achy, but you don't necessarily have the flu. So we would say you're subclinical to having the flu, but you're symptomatic. So this idea of impact is very important because it helps clinicians determine whether symptoms have reached a level where we would consider it to be a mental disorder. You might notice that screen looks a little different from some of the other ones. In fact, this screen that you're looking at now actually comes from the class called Mental Health First Aid, which I'll be talking about a little later in the presentation. So here you see a much more detailed definition of a serious mental illness. The reason I'm showing this to you is because this is what OMH, or the Office of Mental Health, uses to determine whether somebody has a serious mental illness. That's important because we'll be talking later, Glenn will be talking about various different programs in the community for people who have mental illnesses. And we'll also be talking a little bit about housing for people with mental illnesses. And oftentimes, eligibility for those programs is determined by the use of this particular set of criteria that OMH uses to establish a mental illness. So it's not important that you necessarily memorize this or anything like that. This will be available to you in the handouts that Suzanne can make available to you of this slide presentation. And they're also available on OMH's website. But when you examine these just a little bit, you see that the criteria is similar to the slide I just previously showed you about determining a mental disorder. So again, we've got number 1 says there that the person meets criteria of the DSM-5. That just means that they have the symptoms of a mental disorder. And then 2, that they have the symptoms and those symptoms are disabling as determined by virtue of the person being on SSI or SSDI, enrolled in those programs. So again, symptoms that cause impact. So we're still dealing with the same basic criteria. Or if the person's not on disability, it's been determined that they've had an extended impairment in their functioning, again, emphasis on functioning, due to the mental illness, or they've been in treatment for the mental illness for a particular period of time. So again, a little bit more of a detailed definition of mental illness, but conceptually the same. We're really looking at this issue of people having symptoms that are impacting their ability to do life, and then a third variable being duration, that those symptoms are continuing past a few weeks or so, for example. So again, looking at this impact of mental illness on a person's ability and how disabling mental illnesses can be, it's interesting to note that the World Health Organization has determined that globally, depression is the most disabling condition worldwide. it's responsible for most disability. What you see here is a slide that shows a continuum that stretches from less disabling to more disabling. And you see a number of various different health conditions, chronic conditions, and so forth, expressed on this continuum, and where they fall with regard to how impactful they are or how disabling they are. So what's interesting is when you layer in some mental illnesses like severe schizophrenia, severe depression, moderate depression, severe PTSD, just for some examples, and you can see where they fall relative to other conditions on this continuum. And in many cases, they're as disabling or more disabling than some of the things that we commonly think of as being disabling that are physical conditions. So again, this is to drive home this idea that mental illnesses are very disabling, although as a society and a culture, we don't always view them that way. Oftentimes, we see mental illnesses as things or conditions that a person might have more control over or responsibility for than we would physical condition. We might say things to a person, for example, who's depressed, like, just snap out of it, or, try to get through this, or something that suggests that person has more control over their mental illness than, say, one of these other physical disabilities. And the truth is that when a person has a mental disorder without treatment, they don't. They can be very disabling conditions. So that all said, why are people ending up in the nursing home anyway who have mental illnesses? And there are a few different things that will help us understand why this is happening. And I've got two listed here on your screen. The first one is called the Imd Exclusion, or it's Institutions for Mental Disease. And what's happening with the Imd Exclusion is that there was a federal effort made to actually prevent people from being institutionalized with a mental illness unnecessarily. And one of the ways the federal government decided that they might help to stem that problem is to say that Medicaid is not going to pay for a person to live in a congregate setting more than 16 beds if they have a mental illness. We're not going to pay for that any longer. We want to discourage people from living in institutions who are mentally ill. And so you can see where that was a well-purposed policy. But unfortunately, what it's resulted in is, since people can't live in a congregate setting of more than 16 beds and get Medicaid, we often look for other ways that we can find people housing and services when they need it that Medicaid will pay for. And lo and behold, the nursing home is one of those places that Medicaid would pay for and not run awry of the Imd exclusion, therefore creating an incentive for people to be placed in nursing homes who have mental illnesses. And then there's also an issue that goes to the nursing home payment structure itself. And very simply put, the way this works is that the reimbursement methodology in a nursing home won't necessarily pay for a person with mental health symptoms who is very disabled or has a lot of health needs and ADL needs. They won't pay for those. But in many cases, they will pay for a person who had, or I should say, they'll pay for the portion of services needed that are owing to their mental illness. For a person who is less physically disabled and has a mental illness. And unfortunately, what this results in oftentimes is that mental illness is one and sometimes a decisive factor in determining a person's nursing home placement. So we end up with people who might have mental illness and very little other nursing or disabled needs, like ADL needs, for example. So those are two reasons that may be partially responsible for why people are ending up in the nursing home with mental illnesses, and certainly why the prevalence level of people who have been in the nursing home for some time seems to go up. And then finally, I think it's worth mentioning that one of the reasons why we might see people with a higher prevalence level once they've been in the nursing home compared to when they were admitted is simply that they're unhappy. They're unhappy with the situation that they're in, with the living situation that they're living in. They might be desiring more independence, and they find themselves in a nursing home, and it may be contributing to that high incidence of depression that we discussed earlier. So all that being said, how do we determine whether a person who is living in a nursing home or who is about to enter in a nursing home has a mental illness in the first place? That would be helpful. Toward that end, once again, the federal government stepped in back in 1987. They tried to create a mechanism that would help prevent this from happening from people who have mostly mental illnesses from living in nursing homes. And they said, okay, well, one of the ways we can help prevent this is we can screen them before they come into the nursing home. So you may know this thing called a PASR that you see up on your screen here now, or a pre-admission screening resident review, as the PRI and screen. So when a person has a PRI done when they go into the nursing home and the screen, you hear that terminology. What they're referring to generally is this PASR. And the PASR is done in two steps. First, the PASR is done, there's a level 1 and a level 2, which I'll describe in just a moment. But the PASR is supposed to ensure that all nursing facility applicants are thoroughly evaluated, that they're placed in the nursing facility only when appropriate, and that they receive all the necessary services while they are there if they have a mental illness. Now, that's in theory what the PASR is supposed to do. So let's look at a level 1 and level 2 screening process. So before a person comes into the nursing home, they're supposed to have a level 1 screen done. What the level 1 screen does is very simply determine thumbs up or thumbs down. Do we think that this person might, by their record, by their medical record, by the way they're presenting, do we think that they might have a mental illness or an intellectual disability? It doesn't have to be exacting. In fact, it's probably going to result in more false positives than anything if done correctly. If it's determined that, yes, indeed, this person could have a mental illness or an intellectual disability, then that would trigger a level 2 screen being done, which is much more involved. And needs to be done by somebody other than the nursing home. So the nursing home won't do this. It has to be somebody who's independent of the nursing home. So one other exception is that a level 1 screen does not need to be done if a person is expected to be in the nursing home for less than 30 days. So here we see one of the places where we might be introducing people to the nursing home with a mental illness and not knowing it. And the reason why that might occur is because oftentimes people go to the nursing home and the doctor doesn't anticipate that they're going to need to be there for more than 30 days. So they don't do a level 1 screen. Okay, so, and as we know, oftentimes things don't go as planned. And as somebody who was not expected to be in the nursing home for more than 30 days ends up being in the nursing home for more than 30 days. And that person has not had a screen done. So they fall between the cracks. So they might go unnoticed and yet have a mental health diagnosis or some problems. So, but let's assume that the person gets a level 1 is positive and they need a level 2 screen. So the level 2 screen will confirm or disconfirm the results of a level 1. In other words, it will say, well, no, the level 1 was wrong. They don't have a mental illness, or it'll confirm it. And then here are the 4 things that level 2 is intended to address in broad strokes here. So these are the 4 Ds of PASR, I call them: diagnosis, dementia, or the absence of, duration, and disability. Let's look at diagnosis first. So first of all, the level 2 should determine what type of mental illness the person has, and give them and establish an actual diagnosis. It should determine whether or not the person has dementia or not. And this is really important because often dementia is comorbid with different kinds of mental illness and not always easy to differentiate one from the other. So it determines whether there's an absence of dementia. It determines the duration, how long has the person had a mental illness or been treated for a mental illness, and it determines how disabling those the mental illness is. So those are the 4 levels of or the 4 basics of PASS-R. And then what you see here is the kind of information that's gathered in a level 2 PASS-R determination. Now, this should be particularly interesting to you. It's important information to people who are transition specialists and others trying to help people transition to the community who are living in the nursing home, because you can see the rich amount of information that theoretically should be included in a level 2 determination. So it includes their history, medical history and physical, their functional assessment of their ADLs and IADLs. It should include their history of their medication and what kind of medications they've been taken or are taken. It will determine what their IQ is, and it'll determine what their psychiatric history has been. So you can see how that information would be really important to somebody who's working with someone living in a nursing home, not only to determine what that person needs in the nursing home, but more to the point of today's discussion is what will that person need in the community? So what I really stress about the PASS-R to people who may not be familiar with this or even heard of it before is get acquainted with it, be aware that it exists, and if necessary, ask whether or not, in the nursing home, ask, the nursing staff or whoever you need to in the nursing home whether or not the individual you're working with has had a PASS-R. This information would be really helpful for you to have. And you should be entitled to this information if the individual has signed a waiver allowing you access to their health records. So you would want to ask whether or not this PASS-R information exists. That being said, sometimes I mentioned the PASS-R has not been done, or the PASS-R needs to be redone. All right. So there is what's known as a PASS-R reviews. PASS-R reviews are triggered when there's a significant change in status, and that change has a material impact on the functioning of the individual as it relates to their mental illness or intellectual disability status. Okay, so there may be cases where working with an individual, you may be, in fact, the eyes and ears that picks up on that change in condition. Nursing homes, they get very busy. They're focused on the day-to-day needs of people. They don't always pick up on changes in behavior and symptoms that may be developing. Maybe a person is becoming depressed who wasn't before. Perhaps they're experiencing maybe some symptoms of psychosis, and so on. So when a change occurs, is somebody noticing? And if they are, it can trigger a PASS-R re-review, which might be incredibly necessary for a person to be able to receive the proper services. So again, I'll give a plug to the mental health first aid class I'll be talking about in a moment, because in situations like this, it'd be really helpful if folks had some basic working knowledge of what some of the symptoms of mental illness look like, so that you can recognize them when they occur, especially if they were involved in triggering a PASS-R re-review. So just to sum up, a PASS-R is intended for accountability, okay, to make sure that people living in the nursing homes, first of all, hopefully, that they're not there unnecessarily because they have a mental illness, just because they have a mental illness, but also to make sure that if they do have a mental illness, that they're getting the proper care they need. For accuracy, to determine accurately what those needs are, and then ultimately to help drive decisions about access to care, whether in the nursing home or in the community. So all that said, we've talked about people who live in nursing homes with mental illness, why they might be there, the levels that they're there, and how it's determined that they have a mental illness and how that drives the care that they would need. But now I want to segue into talking a little bit about what are those unique needs, and in particular, what's important to know about those needs when you're trying to place somebody in the community to live, and what's unique about people with mental health challenges that would be helpful for you to know. But before I get to that, I want to share some good news with you that should be encouraging. And that goes to your role as a person trying to help somebody transition into living independently in the community. So when we look at predictors of community discharge, you see the first bullet there says psychosocial variables. So things like those conditions that are listed there, and many diseases and things like that, and levels of disability, you know, they really don't predict very well, believe it or not, whether or not a person will be successful or not successful transition into the community. But what we do know is that what really helps a person to be successful in the community is having a person or a support person in their life who's positive toward discharge. And when a person has someone in their lives who's positive toward discharge, it increases their likelihood of being successfully living in the community by nearly 400%. So that, I hope, is encouraging to you, and I hope it underscores for you how important your role is as an advocate for somebody to try to transition them to the community. And I've also added there some information about peers, because if one person helping increases the odds of success, then certainly getting another person involved can only help all the more. And just as some of you might be familiar with peer specialists who help people who have physical disabilities, there are also peer specialists trained and certified to help people with mental illnesses and with substance use disorders. So I would highly encourage you looking into some of those types of peer specialists and engaging them where necessary as a partner to you and a partner to the person in helping them transition to the community. Okay, on that encouraging note, let me get to some of the things that might be things you want to consider, there are some things you want to consider when placing somebody in the community. So a lot of times transition specialists, during this process, many of them had said to us and brought to our attention, one of the barriers to placing people in the community with mental illness is the idea that they resist the idea that they have a mental illness. So it becomes a barrier to helping them, because if someone doesn't admit that they have a problem or accept that they have a problem, it's very hard to get them properly treated and get the supports in line that they need, and for them to be a partner in their own decision making, right? So there are a couple of reasons why we run into this particular barrier. One of them is called lack of insight, and the other is denial, and I'll talk about those just for a moment, what might be going on. If you're dealing with someone who is really resisting the idea that anything is wrong, one of the reasons might be something called lack of insight. People with disorders that involve psychosis, for example, people with schizophrenia and sometimes people with bipolar disorder, experience something called anosognosia, or lack of insight. What this means is it's a psychiatric phenomenon where they actually really do not believe or even know that there's something wrong, that they're experiencing a problem. In their reality, they're fine. In fact, they may see you as the person who is not seeing reality correctly, and they genuinely don't believe they have anything wrong with them. That's important to understand, because if lack of insight is what's going on, no amount of talking, discussing, debating, or any of that is going to convince a person or logic them into the idea that they may have a mental illness. What that person needs is they need an accurate psychiatric evaluation to determine whether lack of insight is involved, and they need proper treatment with medication. So it sounds a little bit like a catch-22. How do you get somebody proper treatment when they don't want to admit that they have a problem? But what they really need is they need to be properly medicated or other type of treatment modality to address those psychotic symptoms so that they stop experiencing lack of insight. But oftentimes, lack of insight is not the problem, but instead what's the problem is the person is simply in denial. And denial, in other words, the person doesn't want to accept the idea that they have a mental illness. Perhaps they don't want the label, or they don't want to have to see somebody who is a mental health professional. We find that denial is generally rooted in stigma. So that the difference again is that a person in denial, they may very well know they're not doing well. They may feel sad and know it. They may feel anxious and know it, but they may not want to admit that they have an anxiety disorder or that they have depression. So the best way to deal with someone who is experiencing denial is to, first of all, start dialogues, not debates, right? We don't want to get into a power struggle with somebody. What we really want to do is seek to understand what they're experiencing, what they're believing, and talk to them and listen to them. So forget the power struggle. Try to focus on building trust and rapport, rather than convincing them that they have a mental illness. You may also find it helpful to talk about mental illness in the disease model. So relating a mental illness to being similar to other types of diseases. So you know that, for example, if you had a broken leg or if you had a really high fever, we would get you help for that. You're experiencing those symptoms. We would try to get you properly evaluated and properly treated. So now you're feeling sad, or you've been really worried, or you've been losing sleep or not eating well. Why wouldn't we just, wouldn't it be important to get help for those things too? So we focus on the symptoms and let somebody else determine whether there's a disorder involved. And again, I'll talk a little bit about a class that will help you determine how to recognize when some of those symptoms might be occurring. So again, here we have two possible explanations for why somebody might be not accepting the idea that they have a mental illness or need help, and how they have different approaches. All right. I want to talk about a couple more things that have to do with barriers to successful transition, or things you want to consider when trying to transition a person with mental illnesses. And when we talk about housing, for example, one of the things that's important to be aware of is this idea of what I'm calling isolation versus autonomy. And the takeaway here really is that people with mental illnesses, like anybody else, they want a certain amount of autonomy in their lives. They want independence. They want to be able to go to their own home, to unlock their own door, to make decisions for themselves, to not necessarily have to check in with somebody at a front desk, and so on and so forth. I think you can understand that. But at the same time, people with mental illnesses also need a lot of support from other people. A cornerstone of recovery from mental illness is yes, it's safe and decent, affordable housing, but it's also having good social supports. So what we want to be careful is, when we're planning for housing options for a person with mental illness, that we don't set them up for failure by isolating them so much that they have no supports in the community. They have no socialization, and they have no peers around who may be experiencing some of the same challenges they're experiencing. What I've put up here is some different models of housing. They're available also on the OMH website, and they're available in this presentation for you to review. My point in showing them to you is just to draw out a couple of important factors that is important for you to pay attention to. The first one is that there are certain housing models out there for people with mental illness that aren't compatible with some of the programs that Glenn is going to be talking about in a little while, i.e. these various different Medicaid-funded community-based programs. So, for example, that first model you see there, traditional CR model. If a traditional CR housing arrangement has more than 16 beds, then Medicaid's not going to pay for Medicaid. That person's not going to be able to be involved, say, for example, in a home and community-based services waiver or something like HARP. And it goes back to what I talked about earlier, that Imd exclusion, right? In institutions that are over 16 beds, Medicaid's not going to pay for that. So you wouldn't want to set somebody up in that kind of a housing model if they needed access to something like HARP. So you see the second model there, the CR SRO level. In this case, it's more of an apartment-like setting. And therefore it's not considered an institutional setting, and it is in fact available for people. Medicaid would be available if you place them in that particular kind of a setting. Other types of arrangements include treatment apartments and scattered site supportive apartments. And the important thing here is, again, treatment apartments may involve a whole bunch of apartments in one building. Somebody may do very well in that setting. They may not do as well if they don't really want all their services packaged together in heavy case management, and maybe they don't want to be living in a setting where everybody in every other apartment all have mental illnesses. By the same token, they may really benefit from living with a couple of people but still having a fair amount of autonomy. In other words, sharing an apartment with somebody. The second model, you see there's scattered site supported housing. And this goes back again to that sort of people living in the community in isolated apartments, similar to what you'd receive if you were in a Section 8 voucher program. And while that may be appeal to some people because of the high level of independence, you just want to be careful of the individual who you're dealing with. And if it's somebody who would really benefit from social supports being around, you may not want to isolate them, at least at first. It may be something that they want to that they may be able to transition into later. So also, when you're looking at housing models, consider whether or not the housing model that you're considering is something that's going to be either permanent or is it going to be transitional. And a transitional step may be necessary to greater autonomy in the future. And then finally, you see a couple more programs here. I want to draw your attention to the second one, mixed use income housing. This can be in many ways ideal because it's an apartment complex model that's very integrated, so that there may be some people living in the building in an apartment who have mental illnesses and recovering from them, and other people who don't. So a little bit more heterogeneous, if you will, mix of people, and that may be appealing to some. So we can get overly focused sometimes. I mean, it's important. There are things we have to set up in the community for a person to make sure that they have what they need, i.e. housing, services, and so forth, transportation. And sometimes we focus so much on that we lose sight of the fact that a person also needs meaningful activities. Especially people living with mental illnesses really do well when they're meaningfully engaged and have a purpose in life. And so one of the first things I've discussed here along those lines is work. And I just want you to be aware that there is something called the Medicaid buy-in program. Glenn will talk about it a little also. The Medicaid buy-in program allows somebody to work without necessarily endangering their status or their eligibility for disability benefits. It allows them to retain a certain amount or actually earn up to $61,000 a year and retain some assets without losing their benefits. So this can be a really helpful program. It's an underutilized program, but it can be a really helpful program for somebody who wants to work and have that meaningful engagement in the community without losing their benefits. Other types of meaningful activities can include, support groups, family, faith, friends, socialization. Again, people with mental illnesses, one of the symptoms of mental illness, especially people with depression, is oftentimes they withdraw from the very things that are helpful to them. So they tend already to isolate and to pull away from and withdraw from social interaction. So it's really important that you don't kind of feed into that by isolating them too much in various housing situations, and that you make provisions for them in their transition plan with their help and their input, of course. What kinds of things would they like to be involved in when they're in a community? Do they have socialization opportunities? Do they have access to family, friends, support groups, things like that? And then some other things might be something called wellness action recovery plans are helpful to people. There's a way to be trained in that. It's a way of helping people to be able to take some control over their own treatment plans and have a plan in place for when they begin to become symptomatic and what can they do that's positive toward their own wellness. And then again, peer supports are mentioned here. So meaningful activities are very important. One more to deal with here with regard to things you should be aware of for successful transition, and that's a person's medication regimens. People living in nursing homes with mental illnesses, they're not always properly medicated. Sometimes they're over-medicated, and there's a variety of reasons for that that you can imagine. Other times they're under-medicated, and they're not receiving the proper medications they need. I think what's really important for you to consider is a person stabilized? Are they receiving the treatment that they need? And this all goes back to, have they had a PASAR? Have they had a re-review when necessary? Are they doing well is really the main point. And if they are doing well, when you transition them to the community, are you making sure that there's continuity in their medication regimen? Are they going to have their medications in hand with a prescription on day one of living in the community? Are they going to have a prescribing physician who's going to be prescribing them the medications that they've been taking? And are they going to have access to those medications from a reliable pharmacy and so forth? So really just what I want to stress here is medication continuity. Make sure that that treatment plan is carried through seamlessly to the community and that there are no bumps, because the worst thing that could happen, or one of the worst things that could happen, was to place someone in the community and totally throw into array their treatment plan. Those things said, I'm going to end on just a note here on something called mental health first aid. I had mentioned throughout the presentation that this would be very helpful to somebody, to any of you actually, working with people in nursing homes to help them with their mental health challenges. What mental health first aid does is it's the help that you give to somebody who's either developing a mental health problem or they're in crisis. And basically it teaches people how to recognize when somebody is struggling, what those symptoms look like, and then how to connect them with appropriate help. It's an 8-hour training program, and it certifies people for 3 years. We take people through a methodology, if you will, similar to what you'd go through in first aid, if any of you have had a first aid class. Most of you probably have. We talk about in first aid things like ABC, airway, breathing, circulation. These things help us remember a sequence of behaviors we engage in to help somebody. And we do something similar when we teach first aid. So we can actually teach you how to assess for risk of suicide or harm. We can teach you how to listen to somebody, how to engage them in a conversation, and give you the confidence and the tools that you need to engage that person in a dialogue and ultimately to encourage them to get help. And then finally, the mental health first aid plan is evidence-based. It's peer-reviewed. What you see on your screen here is some of the outcomes that that they've shown in the research for people who have received mental health first aid, and it increases their confidence, it reduces stigma, and increases their knowledge of signs and symptoms. And that would end my portion of the show here at the webinar. And we're going to just, if you'll bear with me for a moment while we segue Glenn into the presentation. Okay, I would just ask others who are on in the webinar here, are you seeing the screen here that's Glenn's presentation?
Yes, we are.
Okay, so with that, I want to turn the conversation over to Glenn, who's going to talk about some of those services in the community that you can transition people into and how to access them. So with that, Glenn.
Thank you, John. Thanks very much, John. Again, we appreciate this opportunity. John walked you through the process. Now, for those who are engaged with, through the process of engaging and moving into the community, I'm here to talk a little bit about some of the community supports that are happening. And if I were to have this conversation with you a year or 2 or 3 years ago, it would be completely different than the conversation I'm having with you now. So I'm going to take you through a little bit of the process around HARP services, health homes, and SPOA. So I just want to give folks a brief history of the health and recovery plans, better known as HARP services. So back when Governor Cuomo took office 7 years ago, as we know, there was a major budget deficit around $10 billion. So the state was looking for ways to sort of figure out how to, continue to provide Medicaid services, provide other, mental health recovery-oriented services, but at the same time, recognizing the budget deficit. So what he did was he created the Medicaid Redesign teams, which many of you are probably familiar with. Many of you might have even served on some of those teams. So there was one specifically related to behavioral health, given that we know there are a lot of people with mental health issues who have been in and out of hospitals for many years, and they certainly eat up a lot of sort of the, dollars in terms of, funding regarding, emergency room visits, longer hospital stays, etc. So that's when Medicaid managed care came into being as part of the recommendation of the Behavioral Health Medicaid Redesign team. The Medicaid managed care plans have utilized for many years working with individuals with physical health needs for those with mental health illness. So, working in terms of a capitated rate or in terms of, this sort of funding stream is not new to us in terms of individuals with mental health issues from the physical side, but from the mental health side, this was, again, continued to be paid in fee for service. So what we did as advocates, group of us got together and fought to add benefits beyond the traditional covered Medicaid services, because we know what's covered through Medicaid, we know what's traditionally been covered for Medicaid, but if the system were to change as, managed care was moving in that direction, we wanted to make sure that there were beyond just the traditional services that were Medicaidable would now become the option of being, now on Medicaid. So in response to the concern of advocates and the state, that they created a HARP product line that provided additional benefits for 140,000 individuals in the state's public mental health system. So think of it in terms of this. The acronym HARP stands for Health and Recovery Plans. They're a Medicaid benefit product line. They're part of the Home and Community-Based 1959 waiver. So to simplify it a little bit, think of it this way. There are 800,000 people in New York's public mental health system, right? 800,000 people. Out of that cadre of people, 140,000 people qualify for that HARP benefit. That HARP benefit being that enhanced, beyond just the traditional Medicaid services benefit. So again, you have 800,000 people in the public mental health system. All of them are eligible for existing Medicaid plan services. So everybody who's in the public mental health system gets Medicaid can get clinic services, or get inpatient services, get a series of community treatment teams, which are comprised of multidisciplinary teams that go out into the community, generally comprised of a physician, a nurse practitioner, a social worker, a peer, to go out into the community to work with individuals. Personalized recovery-oriented services, PROS, which is sort of the next step around, we talk a lot about continuing day treatment. This is the next step in continuing day treatment, to work with people to get them to the point where they're moving out into the community in more community settings. Continuing day treatment, which is a model that hasn't been used as much as it used to be. Again, you're seeing continuing day treatment much more morphed into the goal-oriented process of PROS. Medication management. Remember, this is behavioral health, not just mental health. So we're talking about detox services. We're talking about residential treatment for substance abuse services. And more recently, a new benefit that was added through the legislation signed by the governor into law last year is opioid outpatient treatment. So that's, again, those are all benefits that everybody in the public mental health system receives. So somebody's leaving a nursing home and might not qualify for a HARP service, they would still be able to garner all those other supports that, I referenced in the last page. So, but the HARP services themselves, okay, for that cadre of 140,000 people, think of that 140,000 people as part of that 800,000 people. Of those 140,000 people, they have a different level of services that are added as an added benefit for individuals. So again, all individuals in HARP services will receive all the benefits in existing Medicaid plan that I just talked about, but they'll also have access to non-traditional services that are now Medicaid billable. So things that we often talk about that help individuals recover. What help individuals recover? Well, nobody recovers in a cookie cutter image. Not one individual says, okay, if I just take my medication and go to a program, I'm going to recover. Well, maybe for some people that does work, but for other people, it is sort of like, well, I need housing, I need supports, I need to be involved and engage with my community with community supports. I need wellness strategies, I need family engagement, et cetera, et cetera. Everybody recovers in a different way. Everybody needs to, get their own purpose in life in terms of their recovery. So we look at it as the Mental Health Association and saying that this is a good thing because it enhances individuals' ability to move forward in their lives. So what would be wrong with adding these as part of the process? So for these 140,000 people, they are getting new services, including peer support. Again, these are services they might have had, but not billed through Medicaid. So peer support, psychosocial rehab, short and long-term crisis interventions, educational supports. Somebody, a lot of people with serious mental health issues, a lot of those 140,000 people might have a diagnosis of schizophrenia or bipolar disorder on the more serious side of the mental health spectrum. And those individuals traditionally drop out of school at age 18, 19, 20 when they might have their first episode. Well, that's obviously when some of them are freshmen, sophomores, even juniors in college, and they drop out, and now they're in the public mental health system, and people are not talking to them about education. Well, you know what? Now, because of HARP services, they will have access to educational supports. They'll have access to employment supports. Well, I say to people all the time, and when I've done this presentation now many times, when I started in this system 25 years ago, the unemployment rate for people with serious mental health issues was 85%. 85% unemployment rate, okay? So 25 years later, the unemployment rate for people with serious mental health issues is, guess what, 85%. So yes, there have been some innovative work that's been done over the years. Yes, there are some really great programs out there, but the reality is there has not been a systemic change that has made such a difference to move people off that number of 85%. So the idea of working with HARP services and working with the health plans is to enhance the ability of somebody and for health plans to recognize how important employment is. Family engagement. Family engagement is a huge piece of this. As a family member myself, I can talk about the importance of family engagement. We at MHANYS have done a lot of work in this in recent years because we recognize how important, if an individual wants to, again, we're talking about individuals over the age of 21, if they want to engage with their family, we think it's incredibly important that they do so and have the ability and the services to do so. We think that's incredibly significant. Self-directed services, non-Medicaid transportation. How often do we hear, especially in rural areas, around issues around transportation? So we say to transition specialist peers, to those of you who are listening to this, you should find yourself, as much as possible, educating yourself about HARP before an individual is discharged from a nursing home. Make sure you're aware of HARP before an individual is discharged.
And I'll just break in, Glenn, because we did find out something new from the Department of Health, that there is a code on Imd that indicates HARP eligibility. So if anyone, transition specialists, want to know if a particular person is eligible for HARP, we can request that information from the Department of Health very easily.
That's great, Suzanne. That's really, and I credit Suzanne and the other folks at the Independent Living Center, because this was an issue that's been brought up virtually at every forum we spoke at, and that's great that you have something that, in terms of some tangible response from the state to this. So really, that's really significant. So again, I would urge people to follow up with Suzanne on that. So thank you. Again, we see the great potential for changing the landscape of behavioral health in New York. People improving their quality of lives, getting and keeping their jobs, getting into school, graduating, managing stress, and living independently. All these are supports that we think are incredibly important, an integral part of the individual's plan of care that identifies their life goals and services. So who with behavioral health needs, okay, is not eligible for Medicaid managed care right now? All right, so we talked about that 140,000 who are eligible. Those who are not eligible are individuals who are dual eligible. I'm using the word eligible a lot here. Medicaid and Medicare individuals. Obviously, if you're non-Medicaid individuals, if you're not on Medicaid, that's somebody you would not obviously be eligible for Medicaid managed care. Individuals in managed long-term care plans, MLTCs. This has been quite a conversation that we've been brought up at virtually every one of our meetings as well. Individuals currently living in nursing homes. Keyword is currently. Again, we're talking about the planful discharge process for an individual. So yes, they might be living in a nursing home now and certainly not be eligible for these services because they're, living in a nursing home. But the theory being, and everything that John talked about, was that they're going to transition into the community. So once they transition into the community, we have to make sure that they will have access. But currently, when they're in the nursing home itself, they do not have access. They do not have the ability in terms of Medicaid managed care. If you're under age 21, and people have services through OPWDD. Now, just to sort of talk a little bit about HARP implementation and obstacles in the way, because HARP is now not new. HARP has been around for, I believe, 18 months in New York City and about 10 months in the rest of the state. So HARP services are not new to people. But implementation numbers are very, very low. So I talk about that 140,000 people expected to be in these services through the HARP statewide. Well, to this point, again, we're talking about timeframes that are not new. We're not talking about a project that's been in existence for a month now. It's been several, a year and a half and over a year, that there are less than 1,000 people enrolled right now, which is a real concern. Now, a lot of reasons why that, it's a new program. It's completely changing the way people think about service structure. So, while the numbers are low, nobody thought they would be this low, but they certainly, and nobody is shocked that, that there's not been a robust sort of, eligibility process going on. So there are a lot of reasons. We believe there are not enough peers who know about HARP services. There has not been a lot of peer education in the community. As a result, people in that community, those 140,000 individuals who are ones who would be in HARP services, don't always know what a HARP service is. It hasn't been explained. And people still think, and they think of HARP services, they just don't understand to this point. Another issue is many providers are still not Medicaid ready. So there's been difficulty in transforming small not-for-profits into Medicaid billing entities. I use us as an example. We at the State Mental Health Association have never billed for Medicaid before. Our members do, but we don't. So, many of our members do. So we were in a situation where, okay, we're going to start billing for Medicaid services for family engagement. This is new for us. We're a small agency. For us to basically change the dynamic, change our financing system, change, all the ancillary issues that go with it, creating all the, the payment structure, the billable pieces, all the clinic pieces, all those pieces, writing out reports and all, this is all new to us. So a lot of small entities, a lot of small non-for-profits are in the same situation. So building up to capacity is itself an issue. The insurance plan, okay, so, whether you're working with Fidelis or in this neck of the woods, Capital District Physician Health Plan, CDPHP, or whoever you're working with across the state, they're not still clear on how the program necessarily works as well. So, a lot of them have been traditional billers for Medicaid services in many situations who have never billed. Okay, they'll bill for, again, going back to my first slide, they'll bill for things like, Medicaid management. They totally get that. Continuing day treatment, they get that. They bill for that. But for them to start talking about things like employment and education, that's a whole new world for them as well. And, what I hear also, the next one is reimbursement rates from some HARP services are not sustainable. There's not, the fee structure, there's not a lot of money in the fee structure and engagement in a lot of the engagement. So that's, that's also an issue. And then obviously there's concern about what's going on at the federal level. HARPs are funded through the Affordable Care Act, the whole process through the Affordable Care Act. And as we know, there have been several iterations, several discussions. I mean, right now, it's, we're not talking so much about the Affordable Care Act as we were a month ago, but we know those discussions can ramp up again anytime. So that's obviously, an additional issue. So those are issues. There's a lot of education training issues. And we are working, frankly, right now, our organization, other organizations, are working with the Office of Mental Health because we believe we want to see HARP services succeed. So we're looking at systemic responses to help them in terms of, ramping up those numbers dramatically. So another story to this in terms of what's going on in terms, when an individual is transitioning from a nursing home into community mental health supports is around health homes. So what's a health home? It's a good question. Health homes are not physical structures. A health home was a national designation through the Affordable Care Act originally. I wish somebody come up with a different name because that alone is so confusing to people when you go and you talk to this. And I've talked to many people about this. When you say the word health homes, They just assume it's a residence, it's a place where somebody lives. It's not. They're not physical structures at all. What they are regional partnerships that are comprised of healthcare and service providers to make sure people get the care they need. And a care manager is assigned to everyone in a health home. All right, so the hallmark of health homes was a number of provider agencies dedicated to meeting needs of consumers through engagements and services, including mental health services and substance abuse services. So I'll show you how this connects to what we're talking about with HARP services. So those who are eligible for a health home are people who have a single qualifying condition around serious mental illness. So you have serious mental illness or HIV, you automatically qualify for a health home. So that means that everybody that I'm talking about, of that 140,000 people in HARP, they all qualify for a health home. Otherwise, you have to have 2 qualifying chronic conditions. Having one chronic condition being a risk of developing another does not qualify an individual as health home eligible. And substance use disorders, while considered chronic conditions, do not by themselves qualify an individual for health home services. But again, it's not hard. Most people, as we know, who we're working with are individuals who probably have 2 qualifying chronic conditions, whether it's beyond, serious mental illness and HIV or substance use disorder. There could be things like high blood pressure, obesity, heart disease, diabetes, et cetera, et cetera. So there clearly are other issues that most people would have. Most people in our public mental health system would likely be eligible for health homes. So health homes, this is where there was a shift. So again, if I was talking to you 2 years ago, I'd be having a much different conversation than I'm having with you now. But because of health homes, there was a behavioral health shift. So traditionally, mental health care coordinators utilize roles as intensive case managers and supportive case managers. That was what the process used to be. So what we would call an ICM, an intensive case manager, an SCM, would go and meet with an individual. In an ICM's case, they'd be a level of intensity of 4 times a month. They would bill for that 4 times a month that they'd see the individual, work with the individual. The health home model changed that and included not only people who were in the mental health system, but brought on a lot of other individuals. Again, those two co-occurring, I'm sorry, just a brain drain there for a minute. For people who were, had other health concerns as well, are now being brought into this system of care that formerly was just for individuals with mental health issues. So there was a lot of confusion about that, and still adjusting to a pretty serious change. So what is clearly needed is more training is needed for behavioral health for care managers, because I won't go into district, but care managers who used to be, again, think of it, intensive case managers, people who knew mental health issues. That's what they did. Now, all of a sudden, not only they work on mental health issues, but they're working on all kinds of other issues as well. So again, those 2 chronic conditions. So they might be working with somebody who has nothing to do with the mental health issues. They might be working with somebody who's got maybe issues around diabetes and heart disease. So it becomes a whole different mindset. So there has to be a lot of work done around mental health education. So again, another talking point that we think is really important to transition managers, specialists, and peers is to take advantage of behavioral health trainings. I know that John talked a little bit about mental health first aid. We do a lot of mental health first aid. It's not proprietary to us. There are other agencies that do mental health first aid training. I would urge you to go to our website at www.MHANYS.org, MHANYS.org, and find out more about mental health service trainings, and find out, we do trainings, our 25 affiliates in 50 counties do trainings all the time. So we would urge you to go into the website and find out how you can get a training. It's really important. Again, other health home concerns, which I won't get into too much for time's sake, but there's frustration voiced about outreach and engagement services. Our workforce is undercompensated. It's all true of all of you in the work you're doing. You know how undercompensated you are and not provided with the resources necessary to engage individuals. And caseloads are very high. Again, it was different in the old days around intensive case manager and supportive case manager, where the workload, the case ratio was not as high. Now in health homes, it's much higher, because you have people some of who frankly don't even need to be on the list. They're low impact, they don't need to be there, but you're still dealing in some cases with ratios of 1 to 50, 60, 70 people. So obviously you know, it's not ideal in some ways. So again, just getting back to the HARP services and the referral process for health homes. So based on past use of services for individuals on Medicaid, 140,000 have been identified as HCBS eligible for HARP services. If you're already in a health plan that provides HARP services, you're automatically enrolled in a HARP. So let me just walk you through, before I end with talking about SPOA and the role of SPOA and how that's changed, because probably many of you are SPOA. I'm just going to walk you through a HARP service process. And really, this is where the rubber meets the road. And if you don't remember a lot of what I say, this is, I think, the most significant take back from what I'm saying, is that the way the process works is the health home or health plan sends a letter notifying the recipient that they have access to a HARP plan. They can choose to stay in that plan or they can opt out of that services, all right? So you've been told, your person you're working with has been notified that they are access to a HARP plan. The letter contains information about choosing a HARP, okay? Do I want to choose a HARP? What do I do next? And most importantly, where do I get information about getting into HARP services? You call New York State Medicaid Choice, and that's the number. Now, if you choose to enroll in the HARP program, you'll be assigned a health home case manager who will provide an assessment to determine a plan of care for HARP services. And this became, the work of us working with ILC, this became a big issue to a lot of us because it was brought up by several people, and I'm so glad, Suzanne, you said what you said, because it was brought up by a lot of people saying, well, we know somebody when they're leaving the nursing home is going to be HARP eligible. Why do we have to wait 2 weeks till they're out in the community before we do have the care plan the care manager come in to do an assessment of the individual? So this is really important, and we're still continuing to advocate that happen. And I'm glad to see the Department of Health, there's a much growing recognition about this as a major issue. Okay, now this is the most important thing I'm going to say today. This is, again, the most important point of engagement for transition specialists and peers to infuse themselves in the plan of care discussion. So once, whether it's before somebody actually goes into HARP services or when they're in the process of, getting the assessment done, this is where the transition specialist or peer has to infuse themselves. What they should do, what we highly recommend, is they talk to the individual, because the individual is working with someone they don't know in terms of the health home care manager. They've never met them before. All they're doing now is filling in an assessment to determine a plan of care, but they don't know the person. You know the person. You can be there and advocate for it. If the person wants, it's up to the person. But you could be there and advocate for the individual. So you can say, for example, Joe, we're going through this assessment process and, you don't seem to be answering the things that you talked to me about were so important to your life. Didn't you say last year that you dropped out of school and your dream was always to go back to college? Well, you know what? Through the HARP service, through this assessment process, through this plan of care, you can have the ability to go back and get an education, go back to school. So this is really, again, where you can infuse it's based on the individual, but this is where you can really infuse yourself into the discussion, because you know the individual probably a lot better than virtually anybody, and you certainly know them a lot better than a health home care manager who's never met them before outside of filling out this assessment. So this is really, it's real important for you to be involved. At that point, after the plan of care is developed, then the health home meets with the health plan to determine the level of services requested in the plan of care. Because remember, the health home is the final biller here, the final payer of services. So the health home is the one who's going to determine, what services you ultimately get. Now, for the next 2 years, to the credit of the state, they're paying for all of this. So there's no disincentive for a health home, for a plan, a health plan, to say, no, that's too many services for that person, or we can't afford to provide those kinds of services for that person. There's no disincentive for them to do that. So finally, what happens in collaboration, the health plan, the health home, through the care manager, and the individual, and again, hopefully somebody like yourselves, will work together to identify community-designated HARP providers who can provide the services in the plan of care. So, in other words, going back to the slide I talked about before, the HARP services, the support and employment, the support education, the family engagement, peer support. Agencies in the counties run these programs, providers. So in some counties, you might have a choice. So when the plan is being developed, say that, an individual is assessed and they want peer support. Well, and they're in Onondaga County, for argument's sake. Well, they can go to Onondaga Case Management for peer support, but maybe there are other agencies that also offer peer support through HARP services. So the idea is to create more choice for the individual. So now that you know all that so well, I'm just going to briefly try not to confuse you more and talk about the SPOA process just briefly, because many of you are probably already available, many of you are already knowledgeable about the SPOA process, because that's where a lot of care management has been done for years and years. And again, flip me back to 2-3 years ago, you're going to see a whole different discussion about SPOA and what it is now. So the roots of SPOA are the initial tenets of care coordination as part of Kendra's Law. Kendra's Law is assisted outpatient treatment programs created through individuals with mental health needs. So the idea of Kendra's Law initially, well, it was court-ordered treatment, but one of the offshoots of what happened with Kendra's Law was that counties and providers came together to discuss referral processes for individuals in a systemic way, including those hardest to serve in communities. So, each county has a different perspective on SPOA, and each county has a different SPOA program. They run it differently, but it was designed originally as an offshoot of Kendra's Law to basically help respond to those in greatest need and create sort of a discussion point about, providers, the county government, and other agencies to sort of make sure that individuals who are hardest to serve had access to treatment. And again, each individual county has their own SPOA. Their traditional line is you've seen one county SPOA, you've seen one county SPOA, and that's very true. So how do health homes and SPOAs intersect? So the adult SPOA for care coordination is not as active since creation of health homes. Health homes have basically taken over the role of the adult SPOA process. So now, what we talked about before with health homes, now they're much more of a linkage to care coordination than adult SPOAs were, though there is still a role. Health homes often will subcontract with case management agencies to do coordination of services. So while some case management agencies will work with a SPOA team in some counties, there are many counties where this doesn't happen. Now, where SPOA and health home intersect is with individuals who are court-ordered with assisted outpatient treatment. So that's really where the SPOA still exists, is for individuals who are court-ordered through Kendra's Law. Now, the other role, we'll talk about the other role briefly. This is the last page here. But now most counties have two SPOAs. There's the adult SPOA, comprised of case management and residential services, and the children's SPOA. So I talked about the adult SPOA, saying that basically, outside of AOT, what is the role for the adult SPOA? It's not as strong as it used to be because of the role of health homes now taking that over. But adult SPOA is still significant in adult housing. And I know John went through all the different categories of adult housing. This is where the adult SPOA is still involved. Health homes are also involved in residential placement, but not to the same degree as SPOA. Most referrals for housing take place through SPOA, except in New York City where it's done through HRA, Human Resources Administration. So again, for the transition specialists, the peers, make sure you have contact information, and most of you probably do, so this is just, but I just want to, reiterate to make sure you have contact information for both the regional health home and the county SPOA program, since they may provide initial entree into the adult system of care when transitioning out of an adult home, of a nursing home rather. So that's really significant that you make sure you have contact information, because again, in some counties, the SPOA and the health home work hand in hand. In other counties, they don't even know each other's names. So you just have to make sure that you have information necessary on both ends. So finally, the last page is a list of resources. I know this is, providing a lot of information in a short amount of time. There's all kinds of other information that's here. You can always contact us directly at the Mental Health Association. We'll gladly, and as I said, there's a lot of information, short amount of time. It can be confusing, but I think it's really important to kind of remember a few of the things I highlighted, that we're talking about 140,000 people who are part of the HARP process, that those 140,000 people get enhanced services, that they would work with care coordinators through health homes, but they would get, again, specialty services and enhanced service structure for them. So that's really, when you think about it, think about those 140,000 people, many of whom were coming out of nursing homes. And again, to my last point, when they are transitioning to the community, they really need your advocacy. You are, the Independent Living Center. I know how mission-driven you are, and I know how strongly you feel about advocating for individuals. That's why you do what you do. So it's really important to, with the approval of the individual, to infuse yourself into those discussions when the plan of care is being developed with the health home individual and health home and the individual. So that's really what I recommend. Again, if you have any questions, feel free to, contact either John or I, through Suzanne, or however you want to contact us. We'd love to respond to any questions you have.
Yes.
So that said, I thank you very much for your time. Again,
Thank
if we can
you,
be a resource
Glenn,
in any
and
way.
we say thank you to John as well. And you can, as Glenn said, feel free to contact us here at NYAIL, and we can connect you with MHANYS if you have any questions that we're unable to answer. But thank you again.
Thank you, Suzanne. I really appreciate this opportunity.